Hi, this is Brian Kim. I'm going to share with you case number 197 in the best way to do cataract surgery series. This is a Catarock. This is a rather dense lens. You're going to see terminal chop, cross chop, mechanical fracturing techniques. And by doing it this way, I feel like this reduces risk for corneal wound burn, posterior capsule rupture, anything that's going to use high ultrasonic energy and high vacuum in an uncontrolled manner because of the potential of post-occlusion surge when you're dealing with dense lenses. And also there's reduced CDE, and as a result, in my experience, clearer corneas post-op day one. So you can see this is a rather dense lens. I'm using the cotton tip to steady the eye. This patient has a little bit of a Bell's reflex. I'm trying to steady the eye and using the corneal marker to help me center and size the rexus. And based on the Bell's reflex, I believe this is a left eye. So I'm going to try to turn the eye all the way to the left. I'm asking the patient to look down. They're having a hard time doing this. And we're just trying to do the best we can. I'm encouraging the patient, look down, look down. They're really having a lot of trouble. So I decide, okay, I'm going to have to hold the eye with the forceps. I really hate doing this, but if the patient's not cooperative, you only have two options. You can do a block, or you can do what I just did. So I grab it with forceps, and then make my incision, first on the right side and the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. So again, if a patient is not cooperative, if you have to, go ahead and grab the eye. That's some intracameral epinephrine and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then when I'm ready, I turn the blade down and then I enter. And this is the sharp tip Haldi-Perkar forceps. Go ahead in sideways and then turn it vertical, puncture the center. Again, this forceps acts like a cystotome, pulls center and towards me, and then I push a little bit to the right to create a flap. Grabbing the right side of the tear, and then I'm going around circumferentially, grabbing and re-grabbing, using the corneal mark that I made as a guide, which will hopefully allow me to achieve a well-centered and sized rexus. Finish off the rexus, burp some viscoelastic out, and this is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge, contra-incisionally, point the tip down, get a nice wave, lift the lens up, decompressing the bag, pushing it back down, sweeping under the rexus edge on the left side and then the right side, and of course the lens begins to spin. I love that lifting maneuver because that decompresses that bag very confidently and easily, which is a challenge if you have weak zonules. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material. And then I go ahead and sculpt. This is the terminal chop technique. I did not come up with this technique. If you look it up online, you'll see the author of the terminal chop. I saw his video at the ASCRS Film Festival. And so I love this technique because essentially what you're doing is two things. You're debulking the central dense core, and that's the hardest part to get through when you're dealing with a super dense lens. So you're going to debulk that central core, which is really, really important. But you don't have to go all the way deep to the posterior capsule, so you don't have to worry about that risk. But then you fracture on the terminal side, as you see right here. I'm fracturing from the side and placing the chopper out to the equator. And by fracturing from the terminal side, you're getting a propagation force fracture point from that end, and you're able to propagate it all the way from one side to the other. And so that's very important, because otherwise, how can you access the most posterior aspect of the lens? Again, if you do it the traditional way of stop and chop, you're only going to fracture from the top, and that's going to cause a Pac-Man effect. This way, you bypass that limitation, and you won't have a posterior plate phenomenon. Place the chopper under the right heminucleus, fracturing the lens in half, and that is the cross-chop maneuver, lifting that first piece up with a little bit of vacuum, getting around it with the chopper, and then crushing the lens and emulsifying the lens. When I do these super dense lenses, I do have a different setting where there's longitudinal as well as torsional phaco energy. Getting around that second quadrant with the cross chop maneuver, crushing the lens between the instruments. Again, doing the cross chop maneuver is very important, and it allows you to get your instruments around the lens completely, and therefore, again, bypassing that posterior plate phenomenon, fracturing the lens in many different ways, but essentially you're crushing the lens, hooking the peripheral lens with the chopper and crushing it against the phaco tip. Again, the phaco tip is acting like a chopping block. So that first heminucleus has been removed. I rotate the second heminucleus in front of me, pushing some more dispersive viscoelastic, turning the water off first, and then pushing some more dispersive viscoelastic. You want to push it over that lens piece so that it protects the corneal endothelium as it comes out. Getting under the orexis edge, turning the chopper vertically, crushing the lens in half. Again, that's another cross chop maneuver, crushing the lens against the phaco tip again. Getting the chopper around that third quadrant, hooking the peripheral lens, positioning the phaco tip deep, grabbing it with some vacuum to reposition. Phaco tip is deep, fracturing the lens completely in half. Again, the phaco tip is deep, the aspiration and vacuum are turned off, so therefore the phaco tip is acting like a second chopping instrument. I'm getting underneath the lens. You can see I'm amputating from the posterior aspect like a scissoring chop maneuver. Again, I'm amputating that posterior adhesion, crushing the lens between the instruments. So again, anytime you have some of those posterior adhesions, you can just rotate the chopper sideways and amputate the posterior adhesion, as you can see here. Again, I place the chopper around that fourth quadrant, crushing the lens, and then turning the chopper sideways, and then amputating the posterior adhesion, as you saw there. Lifting that piece up with some vacuum, positioning the lens so that I'm able to crush the lens between the instruments, and then emulsifying the lens pieces. That's really the hardest part with this, is just making sure you amputate those posterior adhesions. If you don't, you don't have good control of the lens piece. It seems like it's just kind of all stuck together, and it can be rather cumbersome. Oh, I'm sorry, that was the third quadrant. Now this is the fourth quadrant. I place the chopper around the lens, again, hooking the peripheral lens, crushing it in half. And again, this is the last piece, so it's kind of flopping around within the capsular bag. But that's okay. Use some vacuum to position the lens so that I can get the instruments around it, and then I crush it. So again, use a little bit of vacuum, but not too much, and that helps you control the lens piece so that you can get the instruments around it. That's that last big fragment. I'm able to position the instruments around it. And again, this is just a lot of practice. Again, this is purely with irrigation only. No ultrasonic energy or vacuum are used when I'm crushing the lens into smaller pieces. The phaco tip is acting like a chopping block. It is not being used as a phaco tip because the phaco is really used for ultrasonic energy and vacuum. But by doing this maneuver, which is what I've coined mechanical fracturing, again, you're able to use sparing amounts of ultrasonic energy and vacuum. It reduces the risk for post-occlusion surge, and it also reduces the risk for corneal wound burn because you're using judicious amounts of ultrasonic energy and vacuum. Trying to grab those last pieces before I come out. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally, removing the cortical material from anterior to posterior. Oftentimes, these super dense lenses do have weak zonules, so I'm really mindful when I'm doing cortical cleanup. And if you see that puckering effect on the posterior capsule, that tells you you're dealing with some weak zonules. Go ahead and polish under the rectus edge, removing the lens epithelial cells. Polishing the subincisional area as well. Pulsing BSS into the subincisional capsule fornis. You can see there's a bunch of stuff coming out now. Just goes to show, unless you check, you don't know. And there's quite a bit there. Obviously hiding underneath the peripheral iris because you can't see it. So again, I like that maneuver. That does take some bimanual dexterity. And so just be careful if you're going to do that maneuver. You don't want to accidentally poke the posterior capsule when you do that. Go ahead and push some cohesive viscoelastic to fill the bag. Turn the irrigation off as you do this. And then I'm going to go ahead and polish with a sweep. First on the left side and then the right side. I like this sweep. It does have a sharper edge. It's a more efficient way to polish. And it has that large paddle as well, which makes it easier to polish. With these really dense lenses, again, I tend to believe that there's some inherent zonulopathy with these dense lenses, and therefore I like to use 3-piece lenses in these cases. So I widen the incision to accommodate the cartridge in the injector. Go bevel down, turn the bevel to the left. The leading haptic is going into the capsular bag. Rotate the barrel counterclockwise to allow the optic to come out flat. And then this is a Maltzman to dial the trailing haptic into the capsular bag. With the INA, I go in with irrigation off, activate irrigation, and then quickly go underneath the optic. If you take too long, then the fluid stops because I have that continuous infusion on. And so you quickly go in, go underneath the lens, and you're able to do this very quickly and efficiently without the chamber collapsing. Removing the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a dense lens. You saw terminal chop. And again, like I said, I did not develop that technique. Another surgeon presented this video on the SCRS, and I've been using it ever since. Again, you're debulking the central dense core and then fracturing from the terminal side, just like you would for like the double chop technique. You're placing that chopper out to the equator, but by fracturing it from the terminal side, that's really the easiest access point because it's peripheral, but that same lamella of the lens goes back towards the posterior capsule, and you're able to fracture through and through. You can't crack it from the top. You'll get a Pac-Man effect in the posterior plate phenomenon, but then you're able to fracture the lens completely in half with terminal chop, and then with successive cross chop maneuvers and scissoring chop maneuvers to amputate the posterior adhesions, you're able to very carefully fracture the lens into smaller and smaller pieces using mechanical fracturing forces, and then using pulses of ultrasonic energy and vacuum. By using sparing amounts of ultrasonic energy, the risk of corneal wound burn is much reduced. And because you're not having these big chunks of lens material, that's when you get that post-occlusion surge, when you're buzzing and you're buzzing and buzzing, and then you have that sudden loss of resistance, and then the posterior capsule wants to come flying up at you. When you're breaking the lens pieces into small pieces and then using sparing amounts of ultrasonic energy and vacuum, the chances of post-occlusion surge are much lower, and therefore the risk for posterior capsule rupture is much lower. And of course, you're using less ultrasonic energy, which means that there's less endothelial trauma. And in my experience, you'll have clearer corneas post-op day 1. And patients, of course, love that because if you have clearer vision right after surgery, that makes a very convincing and positive experience and impression. But more importantly, that means you've done safer surgery, less trauma to the eye, and this is why I believe this is the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.